Committee will come to order, and I will not ask for a quorum. Good afternoon and welcome. The chair will recognize himself for 5 minutes. Let's see. My opening statement here. We're going to consider two bills at the markup today. The first one, H.R. 1063, the Strengthening Medicare and Repaying Taxpayers SMART Act of 2012, works to improve the integrity of Medicare provider payments. In instances where Medicare has paid a claim but another entity is deemed responsible for the payment, the Medicare Secondary Payer Program is charged with recouping these funds to the Medicare Trust Fund. It is an important safeguard for taxpayer dollars and Medicare solvency. It is also a program which can be improved. Although Congress has sought to improve Medicare secondary payer over the years, most recently in 2007, problems still persist. Today, many injury claims cannot be settled in a timely or conclusive manner because of the actions of CMS. Under current law, CMS is not required to, and therefore it doesn't, provide the amounts either due or that must be set aside to cover future payments so that parties can resolve their Medicare obligations during settlement. As a result, party settlements are often delayed or settlement amounts placed in escrow until CMS can deliver a final amount, a process that often takes years. This lack of a timely response has created a costly legal nightmare for large and small businesses and created undue hardship on beneficiaries through no fault of their own. The SMART Act makes several improvements to the Medicare Secondary Payer Statute to fix these problems, which will benefit Medicare beneficiaries and taxpayers alike. And I'd like to recognize Dr. Murphy for the considerable time and expertise that he has given to the issue. I also want to thank Ranking Members Waxman and Pallone, as well as Chairman Pitts, for working together to prepare the bill for consideration this afternoon. The committee will also consider H.R. 1206, a bipartisan measure that addresses the devastating consequences of the President's health care law for insurance agents and brokers, which have a ripple effect on the insurance market and consumers. Section 1001 of the Patient Protection and Affordable Care Act contains what is known as the medical loss ratio requirement, otherwise known as the MLR rule. PPACA's MLR requirement gives HHS sweeping power over the design of health insurance at the expense of consumer choice. The MLR rule also punishes agents and brokers who help families and employers find an affordable health plan that best fits their needs. Here's how one Michigan agent described the consequences of the MLR. It's going to limit our ability to retain staff to service our clients. With significant cuts to commissions, we would be forced to reduce the amount of dollars that are reinvested into our clients and into our businesses. Significant portion of the agent and broker community will be out of work, along with the cuts in staff for those who manage to stay in business. That's only going to drive higher unemployment costs for Michigan, which is already a seriously strained budget. Another Michigan agent told us that the continued downward adjustments to commissions would make it difficult to survive. Current margins are extremely low for the work that an agency does, and impacting them will cause many agencies to not even exist anymore. So, the Access to Professional Health Insurance Advisors Act is a bipartisan solution that begins to address this growing problem created by the health care law. It has 220 co-sponsors. It has the support of conservatives and progressives alike. H.R. 1206 amends PPACA's MLR to exclude compensation paid for licensed independent insurance producers from the premium portion of the MLR calculation. This much-needed change is going to help stem the negative impacts of the MLR on America's agents and brokers, many of whom are small businesses. The bill will also ensure families and employers continue to have access to qualified professionals who can assist them in finding an affordable, high-quality health care plan. So this bill also requires HHS to defer to state insurance commissioners regarding requests for MLR waivers in order to ensure consumer access to a robust choice in health plans. Michigan's request for a waiver was denied, despite warnings from our state that MLR threatens to destabilize our individual health insurance market. Michigan, not Washington, should make that decision. Again, I want to thank Mr. Rogers, Mr. Barrow for taking the lead on this bipartisan initiative, urge my colleagues to support it, and would yield now to the ranking member of the Health Subcommittee, gentleman from New Jersey, Mr. Pallone, for 5 minutes.
Thank you, Chairman Upton. Let me quickly just say that I'm pleased that the committee was able to come up with a bipartisan consensus on 4 health bills that were marked up in subcommittee last week, and these bills are being considered on the floor this evening, and I look forward to their swift passage by the House before we adjourn. Today we're marking up 2 other health bills, one that deals with the Medicare secondary payer MSP program and another that would reverse the MLR requirement under the Affordable Care Act. Unfortunately, I can only lend my support to the former bill. H.R. 1063, the Strengthening Medicare and Repaying Taxpayers Act, includes sensible and meaningful changes to the MSP program that I believe will have a positive impact on the process for all stakeholders involved. I'd like to commend both sides of the aisle and the sponsors of the bill for working diligently to improve the original bill. In 2008, Congress expanded and strengthened the MSP program, and while good intention, the Centers for Medicare and Medicaid Services and stakeholders have struggled with the changes. While CMS has implemented a number of helpful changes in response to stakeholder input, it is clear that more needs to be done to help further smooth the process. And this legislation would ensure beneficiaries can get needed information to expeditiously reach settlement. It would also have CMS establish a nuisance threshold for all claims, which means they shouldn't be chasing $5 claims if it costs CMS $100 to recover the money. The bill also improves the reporting and penalty provisions and clarifies the statute of limitations. I understand that staffs are still working through some technical edits to the bill, which will be presented in an amendment in the nature of a substitute, but the substance remains the same, and I look forward to this bill's progress. Unfortunately, however, H.R. 1206, which carves agents and broker commissions out of the MLR requirement, represents a detriment to health care premiums and consumers. Nearly 13 million Americans have received $1.1 billion in premium rebates because of these MLR protections. Beginning last year, health insurers in the individual and small group markets were required to meet an MLR of 80%, which means they must spend at least 80% of premiums on medical care and quality improvement activities. No more than 20% of premiums may be spent on administrative expenses like marketing and profits, and that includes commissions. It seems to me that this should be a common sense insurance reform. Why should an insurance company get to spend the medical portion of a premium or commission? That's just simply not right. So currently the MLR requirement is working, and it's putting downward pressure on insurance premiums as insurers with high administrative costs work to become more efficient. If passed, this bill would change that progress and instead drastically decrease insurers' accountability for spending consumers' premium dollars responsibly. And what the bill sponsors won't tell you is that if passed, this bill does nothing to ensure agents and brokers' commissions actually increase. Now, what I have continued to struggle with when discussing the MLR requirement is why the sky is falling. I just don't see it. In fact, my home state of New Jersey has had requirements such as these over a decade, and agents and brokers this past year maintained a healthy commission in the small and individual group market of 7%. Agents and brokers have and will continue to have an important role to play in the health insurance market. In fact, they will have an even bigger role once millions of new customers are in search of health insurance after 2014. So if New Jersey agents or brokers can not only survive but succeed, why can't they in other states? In addition, according to the Insurance Information Institute, agent and broker jobs increased. They did not decrease, but increased by 7,000 since May of last year and by 3,100 since this past May, while the medical loss ratio consumer protection was in effect. Meanwhile, nearly 90% of insurers today are meeting the current medical loss ratio consumer protections as agents and brokers continue to operate. So I don't see the sky falling. I think, everybody seems to be doing fairly well and probably will do better in the future. So I urge my colleagues to reject this misguided and I consider misrepresented bill as well. I yield back, Mr. Chairman.
Gentleman yields back. The chair would recognize the gentleman from Florida, Mr. Stearns, for 3 minutes for an opening statement.
Thank you, Mr. Chairman. Let me thank you for having put these bills up for a markup. I'm a co-sponsor of both of them. And the first bill is the access to professional health insurance advisors. Under the restrictive medical loss ratio rule in the health care law, Insurance brokers have been hit hard. Many of these small business brokerages operate on a commission basis and work hard to provide low-cost insurance plans that fit the needs of small businesses and individuals. They're the ones working to reduce the number of uninsured. However, under the law, they will be hit hard and penalized by the MLR rule. Many states, such as my home state of Florida, have asked for a waiver from the MLR rule, but most, my colleagues, have been denied. The National Association of Health Underwriters testified that brokers serving the individual and small business markets are seeing revenues slashed by 20 to 50%. They found that in Florida, 77% of Florida agents and brokers have seen a decline in revenue last year. We need to pass H.R. 1206. It is a jobs bill. This bill will ensure that agents and brokers will continue to be able to practice their profession and help individuals and small businesses find health plans that best fit the needs of their employees. The second bill, the SMART Act, H.R. 1063, last year, as chairman of the Oversight Investigation, I had a hearing into the Center for Medicare and Medicaid Service, CMS, administration of the Medicare Secondary Payment Program. My colleagues, the results were astounding. The Chief Financial Officer and Director of the Office of Management and Budget were unable, simply unable, to answer basic questions such as this: the number of small dollar amounts outstanding, the response time for getting information and payments to beneficiaries, the median amount of money involved with the 413,000 outstanding cases, the threshold for not seeking funds, and how much CMS is failing to collect, and an inability to provide duration time for the claim settlement. So the SMART Act makes a series of common sense reforms to the system. It will establish a 3-year statute of limitation to prevent the government from harassing seniors several years after the initial accident. It would also require CMS to establish a threshold. They do not waste money going after low-dollar claims. In fiscal year 2010, CMS issued 38,000 notices for amounts less than $1,000, 8,000 of those notices for an amount less than $100. Meanwhile, there are 35,000 claims that were each more than $1,000, totaling more than $375 million. This bill will require information to be given to claimants in a faster fashion, allowing these individuals to reach a settlement quicker. CMS shouldn't be wasting their time in harassing seniors for low-dollar amounts. The SMART Act and the Access to Professional Health Insurance Advisors are two terrific, wonderful, good bills. I support their passage, and I hope we get them through the Senate.
Thank you. The Chair would recognize the distinguished gentleman from the great state of Michigan, Mr. Dingell, for 5 minutes.
Mr. Chairman, thank you for your courtesy, for the recognition. Mr. Chairman, I find that the committee in the legislation before us is batting 50%. Probably good in the big leagues, but not good here. I am troubled that in the 11th hour we have one good bill, H.R. 1063, which demonstrates reasonable common sense bills can be created when members on both sides of the aisle come together. And, Mr. Chairman, you have led us well on many occasions, and this pleases me. The bill will work to make sure that Medicare's secondary payment system is more efficient and doesn't waste taxpayer dollars. For example, Medicare will no longer go after bills that are worth less than the cost of recovery, and ensures that CMS is providing beneficiaries with their final conditional payment amount in a timely manner. I am pleased to offer support for this bill because I believe it does improve Medicare's secondary payment system, protects our beneficiaries, returns money to the trust fund that is owed in a more efficient manner. I am compelled to be very distressed about the second piece of legislation before us, H.R. 1206. I applaud my friends on the other side of the aisle for finally seeing the light and giving up on trying to take part bit by bit. The legislation makes our Americans have access to quality, affordable health care. After 30-odd attempts to repeal the Affordable Care Act, they're now trying to improve it. And I must confess that while I applaud these efforts, H.R. 1206 is not the way to go about improving our health care system. The medical loss ratio means that the insurance companies must spend the vast majority of hardworking Americans' dollars on health care, not administrative costs and not goodies for their officers and shareholders. The MLR guarantees that between 80 and 85% of the premiums insurance companies receive must go towards patient care and administrative costs and cannot be allowed to exceed between 15 and 20%. This makes splendid sense to anybody to whom it is exposed. And it is working, Mr. Chairman. Most insurance companies have been able to meet these benchmarks, and those that haven't met this reasonable standards have begun sending out rebate checks to their customers, which are joyously received by people who find that they have been somewhat badly and shabbily treated by their insurance companies. Well over 100,000 people in my home state alone have received rebate checks for about $200. I can guarantee you that these funds are being used much more beneficially by American families than they would have been by insurance companies with too much bureaucracy or with the determination to live well at the expense of their clients. It is vital to maintain the level of efficiency that MLR creates in order to sustain the highest quality health care for everyone in our nation. Everybody has to give to make this system work. And all we're making the insurance companies do is give up a little excess of which, or rather from which they're extracting from our people who are having to grub around hard to pay the premiums. H.R. 1206 would only limit the rebates that consumers will see under the 80-20 rule and hurt the progress made under the current rule to increase administrative efficiency in our healthcare system. It is for these reasons that I deplore H.R. 1206 today, and I urge my colleagues to vote against this bill. Thank you for your courtesy, Mr. Chairman.
Thank the gentleman from Michigan. I would just note that originally we had 4 more bills that were scheduled today, but we moved them directly to the House floor. So that's 5 out of 6. So that's even better than
Mr. Chairman,
that and 500.
You know of the respect in which I hold you.
Chair now recognizes the gentleman from Georgia for an opening statement. Dr. Gingrey for 3 minutes.
Mr. Chairman, thank you very much. And just listening to my colleague from Michigan, the distinctive ranking emeritus member, a lot of what Mr. Dingell said, I certainly agree with. And when you think about CEOs of health insurance companies making a gazillion dollars and having golden parachutes and all kind of benefit programs, obviously this is, I think, the intent of the MLR provision in the Affordable Care Act was to get at the root of this, to try to rein in some of these excessive profits, as he said, and I quote, not goodies for officers and shareholders. I remember a few years ago reading an article in the Wall Street Journal about a particular CEO of one of the large health insurance companies in the country. I can't remember who it was or the name of the individual. I do remember that the individual had formerly been a physician, and certainly as a doctor, practicing physician, he didn't make the $15 million salary that was reported in this particular article. So it seems to me that the whole idea of putting in the MLR at 85% for the larger companies and 80 or vice versa, 80% for the large and 85% for the smaller companies, it makes sense. But to extend that to insurance agents and brokers and count that against the MLR ratio, I think, was just a mistake. And I would think that our colleagues would recognize that. Let me just read from a recent survey of nearly 2,400 independent health insurance agents and brokers conducted in February of 2011 shows that just 1 month after the MLR regulation went into effect, more than 70% of health agents experienced a decline in their business revenue as a result of PPACA. The survey also shows 25% of respondents reporting business revenue reductions of 21% to 50%, and an additional 25% reported losses of between 11 and 20%. According to the Bureau of Labor Statistics, the average income for agents and brokers ranges from $45,000 to $62,000 a year, not $15 million. In fact, entry-level agents make less than $26,000 their first year. If current commission reduction trends continue, the average health insurance broker will be making around $38,000 annually, far less than the average American worker. In an economic climate where job opportunities are scarce, especially for trained professionals and full-time workers, the MLR, as currently structured, is causing irrevocable harm to hundreds of thousands of small businesses and jeopardizing desperately needed American jobs. And so here again, I think that this is a good bill, a real good bill. It's a job bill, and I think we ought to have bipartisan support on this and pass it on the House floor, and I commend the author, and I yield back.
Gentleman's time has expired. Chair would recognize the gentlewoman from Illinois, Ms. Tchaikovsky, for 3 minutes.
Thank you, Mr. Chairman. I am pleased that we could work together in a bipartisan manner on H.R. 1063, the Strengthening Medicare and Repaying Taxpayers Act of 2011, which would make necessary changes to the Medicare Secondary Payer Program needed for Medicare beneficiaries to reach finality with regards to certain settlements, including workers' compensation and personal injury claims. But I am disappointed that we're considering a bill that, in my view, would weaken Obamacare's medical loss ratio requirement. It's undeniable, I believe, that the MLR requirement is working. This provision is helping Obamacare to deliver on its promise of affordable coverage by putting downward pressure on premiums. Consumers are getting guaranteed value for their premium dollars. Insurers must spend 80 to 85% of premium dollars on medical care and quality improvement. Insurers who fail to do so must provide rebates to consumers. And this August, insurers who failed to meet the MLR requirement issued rebates totaling more than $1.1 billion to 12.8 million Americans, including almost $62 million to approximately 300,000 Illinoisans. I have met some of those happy consumers. Prior to Obamacare, insurers could apply this $1.1 billion in premium dollars to profits, CEO compensation, and marketing. Now, because of Obamacare, this $1.1 billion was returned to consumers such that they could apply their hard-earned money to their own expenses and savings rather than insurance company profits. H.R. 1206 would take us in the wrong direction. This bill would weaken this important consumer protection. H.R. 1206 would decrease the value that consumers receive for their hard-earned premium dollars and allow insurance companies to increase premiums and their profits, but not deliver any medical benefits in return. This bill would also decrease the downward pressure on insurance companies to lower premiums. I agree agents and brokers play an important role in helping consumers purchase health insurance. However, we should not weaken insurers' MLR rate requirement to pay for them. The compensation of agents and brokers should remain where the National Association of Insurance Commissioners recommended and exactly where it belongs, in the 15 or 20% of premium dollars reserved for administrative and other costs. And I yield back.
Chair would recognize the gentlelady from the Virgin Islands, Ms. Christensen, for 3 minutes for an opening statement.
Thank you, Mr. Chairman. The two bills we're considering today are both very important, but I too am pleased that for one of the bills being considered, H.R. 1063, our colleagues on the Health Subcommittee have worked together to address and reconcile as much as possible the key concerns as it pertains to strengthening and, perhaps more important, protecting Medicare and the financial viability of the Medicare Trust Fund. However, the other bill we're considering, H.R. 1206, the Access to Professional Health Insurance Advisors Act, unfortunately lacks that same level of broad-based collaborative attention and resolution. This bill would undermine a provision, the medical loss ratio, of the Affordable Care Act that not only was widely applauded and signed into law, but that's already yielding tangible positive results. It's widely recognized that because of this provision, some insurers have lowered premiums and spent premium dollars more efficiently. Also, because of this provision, as has been said, almost 13 million healthcare consumers received $1.1 billion in rebates from health insurance companies who failed to do what they were supposed to do under the ACA, to spend at least 80 to 85% of premium dollars on actual medical care or efforts that promote quality improvement for the patient. And instead, they diverted those valuable monies to administrative costs, advertising, and or executive bonuses. While there's no doubt that those rebate checks were appreciated, even more important is that under the ACA, we now have an effective way to hold health insurers to a standard that puts patients' health care and well-being first. So finally, health in the healthcare system is being put first. As a physician and as chair of the Congressional Black Caucus's Health Brain Trust, an entity that has been advocating on behalf of those who do not have a voice often for many, many years, I clearly have concerns with H.R. 1206, but I don't stand alone in my opposition to this bill. In fact, I stand proudly with friends from SEIU, Families USA, the National Partnership for Women and Families, the National Women's Law Center, and so many others. While change is not easy, change is often right. It's often can be just. And that sentiment is precisely what led to the inclusion of the medical loss ratio in the landmark healthcare reform law. We cannot and we should not go back. We should be critical of H.R. 1206 because if it passes, it will catapult us back and force us to revisit a time when some could benefit from a broken healthcare system that allowed a few to gain exponentially at the expense, a health and morbidity expense of many others, and there's nothing just or fair about that. So, Mr. Chairman, I look forward to the markup and hope that we as a body continue to move in the right direction forward and down the right path that was established in the Affordable Care Act. Thank you, and I yield back.
Gentlelady's chair has expired. Chair would recognize Mr. Green for 3 minutes for an opening statement.
Thank you, Mr. Chairman. Just for the record, I just appreciate this beautiful green paint in here. I know there were some comments in an earlier hearing, but it's soothing. I think it makes our committee.
We were thinking of you with that big white eagle.
So, but I appreciate it. Thank you for allowing me time to speak, Mr. Chairman. The bills before us today are both bipartisan, and I'm pleased that we're working on bills supported by both sides of our committee. I'm a co-sponsor of the Strengthening Medicare and Repaying Taxpayers Act. The bill makes necessary improvements to the Medicare secondary payer program. I am concerned with the other bill before the committee, H.R. 1206, the Access to Professional Health Insurance Advisors Act. I like working with Mr. Barrow and Mr. Rogers, and I agree with them on many things, but this is one I disagree on. The medical loss ratio was a big part of the Affordable Care Act. When we purchase health insurance, we believe that our premium dollars are going toward keeping us healthy. The essential premise to the insurance is pooling risk and resources to defray the cost of health care that we pay when we actually use it. Before the MLR, health insurance companies would provide the least amount of health care possible while charging the market the most it would bear. The Affordable Care Act says his insurance must spend 80% of the premium dollars on keeping their customers healthy. This isn't unreasonable. Medicare functions on less than 5% overhead. 20% allows companies to pay a profit, pay their executives private bonuses and to their hardworking and deserving staff. It allows them to make capital improvements when necessary. 90% of insurers are able to comply with this threshold last year. I understand why insurance agents are concerned, and I met with agents in our district. And frankly, I worked with agents, both health agents but also property and casualty over my whole career, and I sympathize with their anxiety. No one wants to see their pay decrease or their job loss, especially right now when jobs are so hard to come by. But weakening the medical loss ratio would not increase their job security of their pay. Nothing in the bill directs the insurance companies to pay their agents more. It just says agents' pay can be excluded from the MLR calculation. Insurance companies could increase the money they spend on their CEO or their shareholder dividends or many other objectives instead of increasing the money spent on agents. Even more important, it allows insurance companies to spend less on delivering health care, and this would increase the out-of-pocket expenses for health consumers. The Affordable Care Act is not perfect. We worked many hours in this room trying to make it better, but like all legislation, no one gets everything they wanted. This is one of the areas I think we got right, and that's the 80% requirement. In the context of a bigger bill that makes additional changes to the Affordable Care Act, I might be open to changes in the medical loss ratio that would carefully targeted certain pay, employee pay, or insurance agents pay and benefits. I'm pleased that members from both sides of the aisle on this committee are working together toward making improvements. But I am opposed to H.R. 1206, and I yield back my time.
Gentleman yields back. Chair would recognize the gentleman from Pennsylvania and a prime sponsor of the legislation we're considering today, Dr. Murphy, for 3 minutes.
Thank you, Mr. Chairman. Let me try and illustrate H.R. 1063 with a story. 4 years ago, Lorraine Babbage of Washington County in Pennsylvania, then age 73, suffered injuries so severe in a car accident that she'll never fully recover. After surgery, she contracted methicillin-resistant Staphylococcus aureus, an infection, from her rehab facility. Her condition worsened, and she now suffers from dementia. She must receive care 24 hours, 7 days a week at a nursing home. Now, the physical pain in her life is multiplied by the emotional pain in recent years because after the accident, she lost her husband. Then last year, her only child passed away. Her story is heartbreaking and tragic, and it's depressing to learn that Medicare is working against her interests. In the fall of 2010, Lorraine's attorney and the automobile insurer representing the individual who caused the accident reached a settlement. Lorraine would receive damages and the insurer would pay her medical bills. But since that time, the parties have repeatedly asked Medicare how much it owes to the Medicare Trust Fund. The insurance company wants to make Medicare whole, pay them back, and provide Lorraine with a settlement. But CMS, complicated bureaucracy, is standing in the way. So under the Medicare Secondary Payer Act statute, insurers must repay Medicare if the policyholder's negligence led to medical bills for a senior citizen. But the current system is complicated, riddled with bureaucratic delays that are hard to explain. So we put together the bipartisan SMART Act, the Strengthening Medicare and Repaying Taxpayers Act, which fixes these problems and recoups billions of dollars owed by insurance companies to the Medicare Trust Fund. Now, hopefully Lorraine will receive a settlement, but there are also thousands of senior citizens deserving of compensation. But Medicare's broken settlement reporting system is discouraging parties from reaching an agreement. Insurers are walking away from settlements. The taxpayers are not being made whole. In other words, Medicare is owed a lot of money, which they're not getting, and seniors are losing out. By enacting the SMART Act, Congress can help people like Lorraine and thousands of other seniors who are needlessly suffering because Medicare isn't operating effectively or efficiently. Let me add one other story of how this works. In one case, Medicare also made a mistake in a woman who previously had a chest injury, and later they refused to pay her hospital bills for breast cancer because they said she still owed money on another case. This is how absurd this paperwork gets. And in other cases, Medicare is spending hundreds of dollars to chase down $1.59 that someone owes. Let's bring some sense back to this. And I want to also thank, as we move forward in this, Chairman Pitts and Ranking Member Pallone. Mr. Chairman, I thank you too. Thank Robert Horn and our staff, Brian Cohen, Mr. Maxman, and of course Brad Grants and my own staff for all their hard work. Without them, this legislation wouldn't be moving forward. We've taken care of a number of issues in this, and I thank you, Mr. Chairman, for bringing this before the committee for vote, and look forward to this coming before the full House and the Senate so we can solve these problems for Medicare. And I yield back.
Gentleman yields back. Are there other members wishing to make an opening statement? Seeing none, Chair will call up H.R. 1206 and ask the clerk to report.
H.R. 1206, to amend Title 27 of the Public Health Service Act to preserve consumer and employer access to licensed independent insurance producers.
Without objection, the first reading of the bill is dispensed with and will be open for amendment at any point. So ordered. For the information of members, we are now on H.R. 1206. The committee will reconvene tomorrow, probably about 11:45 a.m. I'll remind members that we'll give priority to bipartisan amendments, and we will see you then. Without objection, the committee stands in recess.